The following podcast is part of a certified educational activity titled Critically Focusing Decision-Making and Communication Strategies to Reduce Recurrence in High-Risk HR-Positive, HER2-Negative Early Breast Cancer, modeling best practices for assessing risk, selecting patients for adjuvant CDK4/6 inhibitor therapy, and fostering treatment adherence or persistence. Access the entire activity and complete the post-test at peerview.com/BZV860. Downloadable slides and practice aids are also available.
My name is Sarah Tollady, and I'm a breast medical oncologist at Dana-Farber Cancer Institute. Today, we're going to talk about decision-making and communication strategies to reduce recurrence in patients who have high-risk, hormone receptor-positive, HER2-negative early breast cancer. And we're going to take a unique approach where we're going to model best practices for assessing risk, selecting patients for adjuvant CDK4/6 inhibitor therapy, and really fostering treatment adherence and persistence. Our goals for today are to augment your skills in identifying patients with hormone receptor-positive breast cancer who are at high risk of recurrence and may benefit from adjuvant CDK4/6 inhibitor therapy, to also implement best practices for incorporating adjuvant CDK4/6 inhibitors into individualized treatment plans for patients who have high-risk hormone receptor-positive disease, and to enhance your ability to counsel patients who have hormone receptor-positive early breast cancer about their risk of recurrence, the importance of treatment for risk reduction, and how to manage adverse events and improve adherence and persistence. So we'll start off with the first category, which is focused on risk assessment. So we'll consider a case to really set up the stage for thinking about risk. This is a patient, Amelia, who is a 56-year-old postmenopausal woman who had a routine mammogram that was found to have a mass in her left breast. Imaging demonstrated that there was a 4-centimeter mass as well as an enlarged ipsilateral suspicious axillary node. A biopsy of the breast mass confirmed that there was an intermediate-grade invasive ductal carcinoma that was strongly ER-positive, PR25% positive, and HER2-negative. The lymph node in the axilla was also FNA'd and consistent with breast cancer. Given the node-positive disease, she did undergo staging scans, which did not demonstrate any evidence of metastatic disease. She also had germline testing done that did not have any germline abnormalities. She did undergo breast surgery with a mastectomy and axillary lymph node dissection and was found to have 5.2 centimeters of cancer within the breast, with 2 of 3 lymph nodes that were involved. She did have an Oncotype recurrence score that was sent that came back at 21. So Amelia did go back to see her surgeon after her breast surgery and had an appointment about 2 weeks postoperatively to review her pathology and make sure she was healing well from surgery, and then had seen me back in consultation about 3 weeks later. At that time, we had the Oncotype score back, and she really came in to discuss what her risk was from her breast cancer and then how to think about what treatments could be beneficial. So we'll come back to our case shortly to determine risk, but first we're going to review some of the supporting evidence about what factors are really important for us to think about when assessing what a patient's risk is of having a recurrence. So there's lots of data that is available that has shown that risks of recurrence in patients who have ER-positive breast cancer unfortunately is not just over the first few years after a breast cancer diagnosis, but actually can persist even up to 10 to 15 years later. We can see that patients who have higher lymph node involvement do have higher risk of recurrence, and so certainly that is an important factor that we do keep in mind when assessing risk. But what we have learned is that endocrine therapy plays a substantial role in reducing risks of recurrence, with a risk reduction usually in the range of about 40%. Another thing that we keep in mind about trying to figure out what therapies can reduce risk of recurrence is certainly about which patients need chemotherapy. And we've been very fortunate to have the development of genomic assays that can help us understand which patients benefit from chemotherapy and which patients actually don't benefit at all from the chemotherapy. And so the Oncotype score, for example, has helped us differentiate patients who do need chemo versus not. Initially, this was studied in patients who had lymph node negative disease in the TAILOR-X study, but more recently we've seen data emerge from our expandr, which took patients who had between 1 to 3 positive lymph nodes and randomized them to get chemotherapy followed by endocrine therapy or endocrine therapy alone if they had a recurrence score that was less than 25. And what we found was that patients who had recurrence scores under 25 in general did not benefit from the addition of chemotherapy to endocrine-based treatment, with the exception being that those patients who were premenopausal did seem to derive some benefit from chemotherapy, although I will say it's controversial if the chemo benefits are being driven by the cytotoxic effects of the chemotherapy, or rather maybe suppression of ovarian function. When looking at time frame of recurrence, what you can see is that those patients who have higher amounts of lymph node involvement do tend to have earlier events. As you can see in the red bar, those patients who had more than 4 positive nodes tend to have recurrences in that 2 to 4 year time frame, whereas those patients who don't have lymph node involvement in the blue bar have a fairly constant hazard of risk over time. But that risk can persist many years out, which is quite unique about ER-positive disease compared to other subtypes. To the right, you can see that risk is also determined by stage, very consistent with what we're seeing by the lymph node data, where stage 2 disease certainly has less risk than stage 3 disease. Another important factor outside of just anatomic risk is thinking about genomic risk. And so understanding the results of a genomic assay can help you understand what that patient's risk of recurrence is. Here you can see data suggesting that those patients with a low oncotype score have lower risk of recurrence than those patients with a high oncotype score, with those having a low risk score generally having a risk of recurrence at about 7% at 10 years compared to about 30% at 10 years in those with very high scores. And so when thinking about chemotherapy, we do tend to integrate both anatomic information as well as genomic assay information to figure out who needs treatment. And this can be different based on menopausal status, as we had seen from the R-Expandr study, where those patients who were premenopausal did seem to have some benefit from chemotherapy, even if their recurrence score was under 25, compared to the postmenopausal patients who did not have any benefit to chemotherapy. And so this chart very nicely integrates the complex information of clinical anatomic risk and menopausal status with a genomic assay score to help us think about which patients may need chemotherapy, with those patients having scores over 25 clearly needing chemotherapy. And those patients who have 4 or more lymph nodes involved, generally we are treating with chemotherapy because we don't yet have data for how to integrate genomic assay scores within those patients at this time. Although I will say this is an area that we do need to study more. So I think in general, when thinking about risks, the things that we need to focus on are tumor size, nodal status, and grade, because those pieces of information do really influence risk. But we also need to keep that in mind with other factors like genomic assay scores, and even other scores like proliferation scores can be helpful, like Ki-67, and integrating that with the specific age and menopausal status of the patient. So when trying to discuss all this information with patients, obviously it's quite complex, and there's certainly some guidance that can be helpful. I think things that can help patients really try to understand risk is to make sure that we are taking into account a patient's individual concerns about therapy, understanding what their fears may be about treatment, making sure that we are providing very clear information about risk, but also factoring that in with what treatment options there are to reduce the risk of recurrence, and making sure that we do put into place regular follow-up so that patients have ways to continue that communication over time. I think some strategies that can be maybe not the best ways to approach this would be not providing too much overwhelming details. Obviously, it's an emotional time for patients as it is, and so sometimes we can easily overwhelm them with information. Don't make guarantees about outcomes because certainly it's hard to know what's going to happen. But at the same time, we don't want to be too negative. We just want to be realistic. and take into account their emotions when having these discussions and not rushing the patient through that very important conversation. So we'll come back to our case and think about how we can use this information to understand risk and then think about therapeutic strategies. So just as a reminder, the patient had a tumor that was a little over 5 centimeters with 2 lymph nodes involved that had a recurrence score that was under 25. She is postmenopausal. And so I do think these pieces of information are very critical and in general is enough information for us to understand risk because we have both clinical anatomic information, age, as well as genomic assay score. Generally, if I have a recurrence score, I haven't found that I need an additional Ki-67 to help me understand risk because, again, that genomic assay score has been prospectively validated. And so in this particular case, unfortunately, this patient does have a fairly high risk of recurrence given the larger tumor and lymph node status. And here, I think pretty clearly could benefit from additional therapy outside of endocrine therapy with the CDK4/6 inhibitor. However, if the case was slightly different and the patient's tumor size had been a little bit smaller, maybe over 4 centimeters, I think then the question is, would the patient benefit from a CDK4/6 inhibitor? Because technically they fall outside the strict monarchy eligibility, which was for a patient who had, if they had 1 to 3 positive nodes, they had to have a tumor over 5 centimeters or be high grade. And this patient was intermediate grade, so met eligibility based on the large tumor size. But as we start shrinking the tumor, then would fall outside that eligibility. And so I think this becomes complex about trying to understand who we should give a CDK4/6 inhibitor to. And so I do factor in, in general, risk factors to help me make that decision. So if she had a 4.5 centimeter tumor, I still would think about giving her a CDK4/6 inhibitor because she did have 2 positive nodes, and I'm worried about this risk of recurrence. If we had switched it and made the tumor a lot smaller, maybe over 2 centimeters, but was high grade, what would we do in that case? I think here, if the patient has lymph node involvement, they would have met criteria for monarchy, and so certainly would be reasonable to think about abemaciclib. But if the grade was grade 2 with 1 positive node, then I think it becomes a bit more controversial because with the smaller tumor, the risk isn't quite as high, and so may not have sufficient data to recommend abemaciclib in this case. And then I think to take a further extreme example is here we kind of gave this patient an intermediate oncotype score, but what if that score was super low and came back at 5? Obviously, that means that risk is lower, but does that mean that we would not give abemaciclib even though the patient met monarchy eligibility? I would argue that I would still give a CDK4/6 inhibitor because what we saw in monarchy was that irrespective of proliferation, for example, we saw the relative benefit of abemaciclib to be similar based on hazard ratio. So in this case, even if the patient had a lower genomic assay score, I would say that the relative benefit of abemaciclib is still probably the same, even if the absolute benefit may be a bit smaller. So here, in that case where we twisted it for a lower oncotype, I still would think about abemaciclib in that case. So as a next step, let's think about how we should approach this conversation with patients, and we'll go through a couple of examples.
Mrs. Stetson, yes, you're the breast cancer surgery patient, right? Your surgeon told me you have a high risk of recurrence of your breast cancer, and we really need to discuss your options.
Well, thank you, Dr. Petoniak. I've been worried about my risk of recurrence. Can you explain what that means?
Recurrence is when the cancer comes back. You had surgery, but that doesn't guarantee anything. You need more therapy.
But what does risk really mean?
High risk means you're more likely to have the cancer return. That's all you need to know. Trust me, you don't want to hear the details. It's really, really too complicated to understand.
I I do want more information. What about my cancer makes it high risk? Can you share some statistics? What is my risk?
Let's see. You had a 5.2 centimeter tumor, grade 2 invasive ductal carcinoma. 2 out of 3 axillary lymph nodes tested positive. About a third of patients with lymph node positive, high risk, HR positive, HER2 negative, early breast cancer, they will develop metastatic progression within 5 years. Patients like you have 3 times the risk of having a recurrence within 5 years versus those with low risk features. This is serious.
Is there anything that can be done to reduce the risk? Are there any other treatment options? I don't like taking medications, but I'm scared and worried about this.
Well, chemo is an option, maybe CDK4/6 inhibitor therapy, specifically abemaciclib, and endocrine therapy. No guarantees, but hey, they might help.
Hi, Amelia. It's so nice to see you back after your surgery. How are you doing?
Uh, I'm good. I'm really good. So you told me that I have HR positive, HER2 negative early breast cancer, right? Can you tell me what exactly that means?
Yeah, no, definitely. Well, first, congratulations on getting through that first part of your treatment. I think getting through surgery is a big accomplishment, and I'm glad it went so smoothly. I think what I usually like to do after surgery is really walk you through what was found at the time of surgery and what that means. And so usually what I like to do is kind of write down all the information about what we found and then put it into perspective about what it implies in terms of what the risk is from this cancer, and then think about what treatments we should be giving you to help reduce any risk that this cancer poses. Does that sound okay with you?
Yeah, that sounds great.
So, there are a few characteristics that I think are really important for us to understand about what was found at the time of surgery. And so, one thing that we're looking at is how big was the tumor in the breast that we saw? And so, what we saw was that there was a little over 5 centimeters of cancer within the breast. We also then want to understand, did that cancer get to any of the lymph nodes that are under your arm? And so, as you know, they had done a sentinel node procedure at the time of your surgery. And what they found was that they had removed 3 lymph nodes. And of those 3 lymph nodes, there were 2 lymph nodes that had cancer cells within them. And so that's an important piece of information because we're trying to understand how much cancer there was. The other thing that I like to understand is when I'm thinking about the cancer, what was the grade of the cancer? And what this means is when the pathologists take that tumor that was removed at the time of surgery and they look at it under the microscope, they're trying to understand, do the cells look like they're cells that are growing quickly, or are they cells that look like they're growing more slowly? And so they grade the cancer. They grade it as either 1, 2, or 3, where grade 1 means the cells are really slow growing. And on the flip side, grade 3 means they're kind of fast growing. And in between is grade 2, where they're sort of not quite fast, not quite slow. And your cancer came back as a grade 2 cancer, so what we would call an intermediate grade cancer. And so I think, again, that helps us get some of the information. But then the other thing that we like to understand are the receptors on the cancer. And so you may remember when you were first diagnosed, we had tested for 3 different receptors on the breast cancer: the estrogen receptor, the progesterone receptor, and HER2. And your cancer was what we would call a hormone receptor positive cancer. And the reason we say that is because it had both the estrogen and the progesterone receptors on the cancer, which in essence means that, we all of us have a little bit of estrogen in our bodies, and that estrogen can act like a food supply for the cancer cells. And so your cancer has receptors, so it can, in essence, use that food to stimulate it to grow and divide.
Doctor, does my specific type of cancer place me at a higher risk for having breast cancer recurrence?
So that's an excellent question. And the way I think about it is I put all these pieces of the puzzle together. So the size, the lymph nodes, and the grade and the receptors, and we think, well, what is the risk from this cancer? Because now your cancer has been cut out, right? It's all been removed. But what we're worried about is, could there be a couple cells that somehow got out of that cancer and got into your lymphatic channels or your bloodstream, and so maybe left behind, even again, though you've had excellent surgery? And so my question is, well, that I'm always thinking is, what's the risk that there are a few cells there, and what's the risk that those cells could survive over the next several years? And if they did, could they survive and potentially multiply and land somewhere else in your body and cause a recurrence of this cancer? And if I were to say, you've had excellent surgery, and one thing we know that you will need will be radiation therapy. To usually what we're doing is we're radiating the chest wall and any lymph nodes nearby to help kill any stray cells that could be left behind in that area. But let's say you did your radiation and you said, well, what's the chance that this cancer could come back over the next 10 years? I would say, knowing what we know about the cancer that was removed, that risk is probably on the 40 to 50% side. So it is a risk that's a bit higher than obviously we would want. But there are lots of things that we can do to bring that risk down. And so one of them...
Are there, I'm sorry, well, what exactly increases my risk?
So I think two of the factors that are associated with having a risk of recurrence of breast cancer is the size. And so the size of the cancer was a little bit on the large side, being over 5 centimeters, and having lymph node involvement with those 2 lymph nodes that we found had some cancer cells in them, suggests that there's a little bit higher of a risk, because it makes us wonder if some of those cells could have gotten out into the lymphatic system and into your bloodstream and could leave some cells behind in your body. So that's why we think that risk is on the higher side, because of those 2 factors.
Well, are there any tests that can help you better tell if I'm going to have a recurrence?
So that's also a really smart question. And there is one test that we like to do that actually tells us 2 pieces of information. It's a test that helps us understand what your risk of recurrence is, but it also helps us understand if chemotherapy could reduce that risk of recurrence. And so these are tests that take the tumor tissue that you had cut out, and they look at the gene expression in the cancer. So we can send the tumor, for example, to a company that can extract the DNA from the tumor and run a bunch of tests and understand what that gene expression is to tell us the risk. And so one test we like to send is called an Oncotype DX test. And we actually did send this on your cancer. And the way we look at the score is we've sort of divided into 2 groups. We say that the score is either greater than 25 or less than 25. And if it's less than 25, what we've found is that your risk of having a recurrence is lower than someone who has a score that's higher. And it suggests that you would not benefit from chemotherapy, that these cancer cells would not be well killed by chemotherapy, and so it wouldn't help reduce the risk. And your score came back at 21, so it fell under that 25 cutoff, which again would suggest that giving you chemotherapy actually would not reduce the chance of recurrence. But I think importantly, it suggests that the biology of your cancer is one where the risk is a bit better than someone would have a high score. And so that's actually really good news. And so if we say that chemotherapy is not going to reduce your risk, the question then comes up as, well, what is going to reduce the risk, right? How can we make the risk lower? And in my mind, I think one important and critical therapy is what we generally call hormonal therapy. And that means that because your cancer had that estrogen receptor and it was being fed by estrogen, in essence, what we want to do is get rid of the estrogen so there's no food to supply that cancer. And so if there was a cell or 2 left behind after surgery, that it would die because it wouldn't be getting the food it needs to keep itself replicating. And so that's a really nice trick, actually, to reduce the risk. And so that would be one treatment that we would give, is a pill that can, again, lower the estrogen and help prevent a recurrence. And so that's a really nice treatment that we have. The other thing that we will recommend is a different pill specifically called abemaciclib. It's a type of drug that stops the cancer cells from making copies of itself, what we call a CDK4/6 inhibitor. And so we usually give this pill in addition to the hormone therapy to help further reduce the risk of having a recurrence. And so I think the steps that we think are going to be really important are going to be to start this hormone pill, to do radiation, and then after radiation to start on the abemaciclib, the extra pill that can help prevent a recurrence. And so these are really critical steps, I think, that will make a big difference in helping prevent your cancer from coming back.
Great. That sounds really good. Thank you.
Oh, sure. So I think we'll talk more in more detail about what these therapies mean and what their side effects are. But I think that's, in general, a plan that really does generally work very well for this kind of breast cancer.
Sounds good. Thank you so very much.
Oh, sure. So next, we're going to turn to treatment planning and how to optimally use adjuvant CDK4/6 inhibitors in high-risk hormone receptor positive disease. And so in this particular case, we had a patient who had, again, a tumor over 5 centimeters with 2 positive nodes. And so Amelia, our patient, had seen her surgeon postoperatively and then came back to discuss treatment selection. And so here we'll review what the supportive evidence would be for use of CDK4/6 inhibitors in this setting. And so we do have data from monarchE, which was a large randomized phase 3 study that had taken patients who had what we consider high-risk hormone receptor positive disease. It was defined as having 4 or more positive nodes involved, or 1 to 3 positive nodes with an additional high-risk feature. So the patient had to have a tumor that was over 5 centimeters, be high grade, or have a high Ki-67. Patients were then randomized to get endocrine therapy with or without abemaciclib, where the abemaciclib was given for 2 years. We now have data with 5 years of follow-up and have seen that the addition of abemaciclib to endocrine therapy reduced risk of recurrence almost by a third. So really, I think a very impressive reduction. And this is even after discontinuation of the abemaciclib, because remember, the abemaciclib is only given for the first 2 years. And what we see is that those curves continue to separate even beyond the 2-year time frame, suggesting there may even be a carryover effect from the abemaciclib, allowing us to see this continued separation of the curves. What we also see is that the relative benefits are similar across all subsets, whether the patient had a high-grade tumor or intermediate-grade tumor, whether it was stage 2 or stage 3. Again, all subgroups were deriving benefit. Importantly, distant relapse-free survival was significantly reduced as well, suggesting that the vast majority of the IDFS events were actually distant events. And while when we look at overall survival, there is not yet a statistically significant difference, you can see there's a small separation of the curves. But in truth, I would not anticipate seeing an OS benefit at this time point, because even when a patient recurs with ER-positive disease, thankfully, these patients can live for many years with metastatic breast cancer. And so what I think is important is to look at how many patients actually developed metastatic disease at this point in time rather than the survival. And what you're seeing is that there are far fewer patients with metastatic disease in the abemaciclib arm compared to the endocrine therapy arm, suggesting that maybe with time we will see an overall survival difference. We obviously have to weigh this efficacy with potential toxicities. And one of the most common toxicities with abemaciclib is diarrhea, where we see about 80% of patients do develop some level of diarrhea, but grade 3 diarrhea in general is quite low. It can also cause some neutropenia and some mild elevation of LFTs, and so we do require laboratory monitoring after initiation of abemaciclib. A couple less common toxicities that are important to be aware of are venous thromboembolic events, which can be seen in about 2.5% of patients, and potential risk of interstitial lung disease, where we've seen about 3% of patients can develop ILD. It is important when thinking about the endocrine backbone that you're utilizing to realize that risks of thromboembolic events are slightly higher if you're using tamoxifen combined with abemaciclib, where the VTE rate was around 4%, compared if you're combining it with an aromatase inhibitor, where the VTE rate is lower at about 1.7%. But again, given the very robust data we've seen from monarchE, FDA has approved use of abemaciclib with endocrine therapy in these high-risk hormone receptor positive patients, really defined by the monarchE eligibility. So having 4 or more positive nodes or 1 to 3 positive nodes with that additional high-risk feature, being over 5 centimeters or being high grade. There is also another CDK4/6 inhibitor where we have data suggesting benefit, and that is ribociclib. And this data comes from the NATALY study. This trial had a slightly different approach where they took patients who had high-risk disease, but high risk was defined differently. So you could have a patient who had any lymph node involvement and they would be eligible. So you didn't have to have an additional high-risk feature if you had a positive node, or you could even be node negative if you had an additional high-risk feature. So you had to be at least 2 centimeters in size and either be high grade or, if intermediate grade, needed to have a high genomic assay or a high proliferation score. And so these patients were randomized to get an aromatase inhibitor with or without ribociclib, where the ribociclib was given for 3 years, so longer, obviously, than was done with abemaciclib in monarchE. Important to note that the ribociclib dosing used in NATALY is different than the metastatic dosing, where in the metastatic setting we use the 600 milligram dose 3 weeks on, 1 week off, whereas in NATALY they used 400 milligrams 3 weeks on, 1 week off. And what they found was that with about 3 years of follow-up, they had about a 2.5 to 3% absolute difference with the use of ribociclib in this population. So about a 25% risk reduction from giving 3 years of ribociclib. When specifically looking at node-negative patients, you can also see that there is benefit in this population. The challenge, however, is that it's a smaller subset of the trial. There are only about 12% of patients in NATALY had pathologic node-negative disease. And so you can see the confidence intervals surrounding this benefit are very large and, in fact, cross 1. And so the precision around the exact benefit seen in node-negative patients is not quite as robust. And so I think I would keep that in mind when applying these data to node-negative patients, where I feel like I don't know that we're quite ready to do so, especially since follow-up here is on the shorter side at about 39 months, where some patients were still taking ribociclib at this time because, again, remember, they were getting 3 years of therapy. When thinking about toxicity, we know that patients can have neutropenia from ribociclib. It's less than we see in the metastatic setting, since, again, remember, this is a lower dose, so about 40% of patients will have high-grade neutropenia. The other thing to keep in mind is there can be a risk of QTC prolongation, so you do need to monitor QTC with EKGs at baseline, as well as after 2 weeks and then after 4 weeks. And also to monitor for liver enzyme elevation, because you can see about almost 9% of patients had high-grade elevation of their liver enzymes, and so it does require close monitoring. And so here, when thinking about treatment options and how we should discuss this with our patients, it is important for patients to realize what drugs they're taking and why they are taking them. So thinking about explaining what the agents are, how they work, why they are providing risk reduction, what the duration of the medication should be, what the potential side effects that they could experience are, and then thinking about tricks to help patients with adherence and persistence, because it is a long time to be taking these drugs, and we do need to remember to check in with them about challenges they may be having with staying on medication over such a prolonged period of time, and then importantly to factor in patients' lifestyles and preferences when thinking about these agents. On the flip side, it's important not to overpromise, making unrealistic expectations, not to ignore potential toxicities that can happen, making sure that the treatment decisions are personalized to the patient, and then factoring in any fears or concerns that they may have with treatment. So we'll circle back to our case. And so in our patient, Amelia, what we learned was that Amelia did have a high-risk hormone receptor positive breast cancer based on her clinical anatomic risk. It's important to think about also her other, lifestyle factors, because obviously this is going to play a role in potential compliance with medication and her ability to make appointments. And so Amelia is busy and is a manager who is quite busy with travel, very dedicated to her job. And so I think that's going to be important when thinking about how she's going to make it into appointments, how she may tolerate GI toxicity. Also important to think about her past medical history. She does have some cardiac history with some arrhythmias, slow heart rate, and does see a cardiologist. And so thinking about which CDK4/6 inhibitor to use, thinking about cardiac issues would be important, since ribociclib could potentially cause some QTc prolongation. And so I think all of these factors are important for us to keep in mind. She is generally reluctant to take medication and not so good with sticking with her prescribed medicine. So we'll have to make sure we think about ways to help her with adherence and persistence to therapy. So here in this case, when thinking about what treatment options we should recommend, Amelia's does meet monarchy criteria, given that she had 1 to 3 positive nodes with a tumor over 5 centimeters. So use of abemaciclib would be indicated in this setting. I think the challenging situations are more when patients have more borderline criteria for eligibility, where maybe they didn't quite meet the 5 centimeter mark, or maybe had an intermediate grade tumor with 1 to 3 positive nodes. And so I think those are times where I do try to balance risk and patient preference when making a decision. And in this case, thinking about her individual history is important, making sure, again, she does have some cardiac history where ribociclib may not be ideal. She is going to be traveling, and so GI toxicity may be challenging at first, as well as laboratory monitoring. So all those factors, I think, do need to be taken into account and should be discussed with the patient. So we'll turn back to our patient discussions and go through some examples.
Dr. Petoniak, I would really like to avoid taking chemotherapy if possible. You mentioned this other therapy. Was it like Obema something? How does that work?
Abemaciclib, CDK4/6 inhibitor. It slows down cell division, stops those pesky cancer cells from multiplying. You take it as a pill. It's simple.
What are the benefits?
Benefits. Let me see here. Well, here's the latest study publication. The addition of abemaciclib to standard of care endocrine therapy is the adjuvant treatment of HR positive, HER2 negative, high risk early breast cancer, provided a persistent IDFS and DRFS benefit, with deepening of the absolute benefit in IDFS and DRFS rates at 5 years compared to that of previous years.
I really don't understand what this means, but I mean, it sounds impressive. What are there side effects? What kind of side effects can I expect?
Studies say it reduces the risk of recurrence, and we have plenty of long-term data on this drug, but numbers don't matter. You're not a statistic. Side effects, yeah, diarrhea, fatigue, neutropenia maybe, but hey, it's a trade-off. Cancer or side effects. You pick your poison.
I want to understand. How often do I take it? How long?
Twice a day until I decide. About 2 years. You just follow my instructions and it'll be fine. You'll figure it out.
Dr. Petoniak, I need more than you'll figure it out. Can we discuss, I don't know, quality of life? What can I do myself? Are there any lifestyle changes I could make?
Quality of life is relative. You might feel lousy sometimes, but hey, remember your risk. You decide what's important to you. As far as other things you can do, eat healthy, exercise, you know the drill, and don't smoke or drink too much. It's common sense, really.
So, Amelia, I thought we could get into a bit more detail about some of the treatment options that we have, just so you can understand what some of the side effects could be and how long these medicines are taken for. Does that sound good?
Certainly. Yeah. Thanks.
So I think one of the first treatments that we talked about was using what I call hormonal therapy. So a medicine that's going to get rid of the estrogen. And the specific type of drug that we use is in the category of agents called aromatase inhibitors. And these drugs really work by stopping estrogen production. So it does mean that your estrogen level is going to fall when you take this medication. And so that does mean that you're going to have some side effects that are typical of, I think, what a lot of people call menopausal symptoms. So when the body's estrogen levels falling, a lot of patients will start to notice things like hot flashes, night sweats, sometimes vaginal dryness. It also is important. Estrogen is very important to keep your bones strong and healthy. And so as we lower estrogen levels, we do potentially put your bones at risk for getting thinner, what we would call developing osteopenia or even osteoporosis. And having thin bones, isn't so good because if you were to fall, it would make them more likely to develop a fracture. So we have to watch that. And so we do monitor people's bone health when they're on these kinds of drugs. So we get bone densities, for example, when you're starting the drug, and then usually every 2 years while you're on the therapy. So we will keep a careful eye on that. The other thing some patients notice that can sometimes be frustrating is that people can get some joint aches or pains. And it's not everyone who does, but people who do will say that they often feel kind of stiff, particularly if they haven't been moving around a lot. So first thing when you wake up in the morning, or if you went for a long car ride and you got out of the car, you kind of feel achy. And then when you move around, it kind of gets better. And so those are sort of common symptoms that we often hear about from our patients on these kinds of medications. Generally,
I'm sorry. How is this therapy given?
so it's a pill that you would take once a day. And usually it doesn't matter if you take it in the morning or the night or the afternoon. We just ask that you find a time of day that works best for you. And again, you would just be taking it daily. Generally, we like people to take it, in your case, for somewhere between 7 to 10 years. So I know that sounds like a long time. And so I think, we just take it one step at a time and make sure that you're tolerating it well. But that's the overall goal, is that you'd be taking it for somewhere between 7 to 10 years, depending on, how your bones hold up and how you're feeling throughout that time course.
Yeah, it does sound like a long time. And I, in the past, have not been really good about, going the whole amount of time that a drug is prescribed to me. But if you prescribe this thing and if I need to take it for 10 years, I'll do that.
Well, I think I always tell patients, try not to think of it, in the whole picture, because sometimes that can be a little overwhelming. So we'll
Yeah.
break it down and we'll think about, just one step at a time. And so I think that's definitely the first step, is to start this pill, and that, in this case, we're going to prescribe it called letrozole. And you can go ahead and actually start this, anytime over the next week. And you can be taking this even through the course of your radiation. And so you'll move on to get radiation therapy, and you can be on the letrozole while you're getting your radiation and then continue on it thereafter. But I usually like to see you back again after the radiation is done. One, to check in to make sure you're doing well with the letrozole and you're tolerating it well. But two, then we also start a second pill, and this is called abemaciclib. This is the CDK4/6 inhibitor pill that we were talking about, that really is trying to not let the cancer cells make copies of themselves. And it works very well when combined with that hormonal therapy, and in fact will lead to about a third reduction in your risk of having a recurrence. So it really does reduce that risk very significantly. It is a pill that is taken twice a day, so once in the morning, once in the evening, and our goal is for you to take it for 2 years. So if you remember, we said the hormonal pills for 7 to 10 years, whereas the first 2 years of that, you would be taking the abemaciclib. And so that would overlap only for the first 2 years. Does that make sense?
Yes, it does. Does this one have any side effects?
Yeah, so unfortunately, there's always a side effect from all our medications that can happen, but we do keep a careful eye on things. And so with this medicine, one of the side effects that is pretty common is diarrhea. And, it's variable how the diarrhea is. For some people don't have any. I think the most common thing that I've seen is that people have kind of intermittent loose stools. So, a couple times a week, their stools may be looser or they may go more than once a day, more than their usual. Um, but there are some people who get more significant diarrhea where they're going to the bathroom several times a day. And so it's really important that, we keep in close contact with one another so that we understand how you're doing after you start the medication, because we don't want you to be having lots of loose stools every day because that can make you dehydrated and obviously can become uncomfortable. And so we start you out taking it twice a day, but we do need to monitor it to make sure that you're tolerating it well. There are some tricks. So if you did develop loose stool, it's very good to have some loperamide on hand because this can help stop that diarrhea so that you're not going to the bathroom too much. And so what we ask is that if you notice that you're going to the bathroom, more than once or twice a day, that you do take one of those loperamide tablets. Usually I have you take 2 at the onset of diarrhea. And then we see if it comes back again. If the diarrhea happens again, then you can take an additional pill. But at that point, I do ask that you call our office because I don't want you, taking lots of loperamide at home and having a lot of diarrhea. I want to make sure we're aware of that because sometimes we can stop the medicine for a little bit and let your bowels recover.
Sure. I really appreciate that. I want to get back to, I mean, I have a pretty active life and I travel a lot. And you know, am I going to be able to keep all that up, or how long is this all going to take to get back to where I was?
Yeah, no, it's a good question. Since they're pills, it definitely, you can be on the road and traveling and doing things. But obviously, if you were having diarrhea, that would be challenging. If you're in the airport and trying to find a bathroom and all that, that becomes hard. And so we don't want you to be having diarrhea. And so we do need to figure out how to control it. And usually, I think within the first 2 weeks, we kind of know how you're going to tolerate it because if people develop diarrhea, usually it happens, by the 7th or 8th day that you've been taking the pill for. And so what I often have people do is start it at a time when they don't have a lot of travel so that we can kind of test the waters and see how you do with it and make sure that, you're tolerating it well. And if we need to tinker around with things, sometimes we do need to lower the dose, for example. We can do that before you, take a big trip so that we have things, well tolerated at the beginning. Does that sound reasonable?
Yes, yes, it does. Thank you.
The other thing we'll have to keep in mind is when you first start on the medicine, we do need to check blood counts every 2 weeks for the first 2 months because this drug, the abemaciclib, can lower your blood counts a bit. And we do need to make sure that it's not lowering them too much. And so we do check on that. And so again, we'd have to plan that with your travel time to make sure that we have opportunities for you to come in and get blood count checks for those time points every 2 weeks for the first 2 months. After that, then it becomes a lot easier because if we've figured out the right dose for you and you're tolerating it well, then we can go to once a month visits. And eventually we can even go to every 2 month or 3 month visits as you've been on the medication for longer. And so that does get better over time.
All right. I mean, all this treatment sounds really good. Are there like lifestyle changes that I could make that would increase my chances of this all working out okay?
I know it's an excellent question. I think one thing I tell people who are taking the abemaciclib is, first when you start to watch your diet a bit, because, you can imagine if you eat something that's got a ton of fiber in it, it's going to make you go to the bathroom a bit more. So eating that really big salad, for example, may run through you a little bit. And so at first I tell people if they are having diarrhea to keep more of a bland diet. So, things like carbohydrates, bananas, apples, things like that tend to be kind of easier on the stomach, and that is a nice thing to do until we kind of figure out how you're tolerating it. The other thing I think is really important is exercise. There is more and more data emerging about doing routine aerobic exercise and how that can potentially help reduce recurrence as well. And so that's something that, I generally try to recommend all of our patients do. And then an additional thing that we can think about once you're tolerating the abemaciclib well is I sometimes think about adding what I call a bone strengthening drug. There is some data that these drugs that are often used to just treat osteoporosis, for example, so drugs to keep the bone strong, it turns out that they also can help reduce risk of recurrence, which is really interesting that drugs that can strengthen the bones can actually also help prevent breast cancer recurrence. And so in your case, actually it could have a couple benefits because I'm going to be giving you a hormonal therapy that potentially could thin your bones. And so this could help counteract that, and it could help prevent a recurrence. And so usually I start that after you've been on the abemaciclib for a little bit, and we can talk about adding that in at that time.
Okay.
Do you have any questions about all of that?
No, that was a lot. And I think you pretty much covered any questions that I had coming in.
Well, I know it is a lot of information, and I do want to reassure you that we will break it up and rediscuss all this at each time point. So while you may be just starting on the letrozole now, we will again see you back after radiation, and we'll talk about the abemaciclib at that point. So I don't expect you to remember all of this information at one time. We'll kind of break it up and get into it in more detail each time you come in.
Great. That sounds like a plan. Thank you very much.
No, I'm glad we have a good plan, which I think will be very effective for your breast cancer. So finally, we'll turn to maximizing treatment benefits and minimizing risks and how to manage adverse events and really improve persistence. And so coming back to our case, Amelia, she did start on abemaciclib, but did have some challenges with diarrhea and fatigue. So we will come back and discuss some strategies for adverse event management. But to put it in a context, we'll review some of the data. What we do know with abemaciclib is that diarrhea does typically occur early, usually within the first 3 months. So very important to make sure that patients are aware of that and that we can help them, particularly during that early time frame. We do know that about 40% of patients taking abemaciclib do end up needing some dose modification, usually due to GI toxicity. So it's not uncommon, and again, should be a strategy that we do consider with our patients. I think patients often worry when we talk about dose modification because they worry that maybe we're going to compromise the efficacy of the agent. But a very nice analysis was done in Monarchy where they looked at dose modification and impact on efficacy. And what you can see is that there was no difference in invasive disease-free survival when looking at different relative dose intensities, suggesting that dose modification was not impacting the benefits from abemaciclib. And so when we're using abemaciclib, we start off at 150 milligrams twice daily. If patients require dose modification, we go down one dose level to the 100 milligram twice daily dose. And then if they need further dose modification, you can go down to 50 milligrams twice a day. It is very important to make sure that we check baseline blood counts. So, checking a CBC as well as a comprehensive metabolic panel, checking that again, usually at 2 weeks, 4 weeks, 6 weeks, and 8 weeks is quite important. Again, we're trying to monitor patients in this setting where they could develop some laboratory abnormalities. Also, I find it helpful to check in with them to make sure that we're assessing for GI toxicity. And then beyond that, we usually extend visits to at least, every 2 months or so. I do make sure patients have loperamide on hand before starting abemaciclib so that they have medication to take in case they have some diarrhea, to think about dietary changes because high fiber diets can certainly impact rates of diarrhea, and then making sure that we do communicate with patients so that they're not taking drug through significant diarrhea. And so it's important at the sign of first loose stool to instruct patients to use loperamide, to increase hydration, and to call your office so that you're aware and can help them manage side effects. And then follow up with them closely thereafter to make sure that the diarrhea is resolving and to suspend use of abemaciclib until the diarrhea resolves. And if it's persistent diarrhea, I do think about dose modification. Another thing to keep in mind when you're checking labs is sometimes their creatinine will look elevated. And I think this is always perplexing because you worry that someone, for example, may be prerenal, and this may be the etiology for the elevated creatinine. But it's also important to realize that abemaciclib does impact renal transporters and so can increase the creatinine while not adversely impacting renal function. And so one way to actually assess why the creatinine is elevated is to check a cystatin C, because this is not impacted with clearance from abemaciclib. And so you can assess GFR accurately and try to differentiate if it was just, in essence, kind of a false elevation from the abemaciclib, or in fact, the patient is experiencing other causes, for example, of renal toxicity. With interstitial lung disease, again, very important to assess what the grade is. Are they having symptoms? So it's grade 1, or are they having symptomatic ILD, for example, where it's grade 2? And low-grade ILD, grade 1 or 2, you don't need to dose modify with abemaciclib, but if it's persistent grade 2 toxicity, you do need to dose hold, treat the ILD until it improves, usually with steroids, and then once it's resolved, you can restart the abemaciclib, usually with dose modification. With hematologic toxicity, I think we're all pretty familiar with this with abemaciclib. For grade 1 or 2 heme tox, you don't need to dose modify, but with grade 3, you do need to hold until it resolves, and don't necessarily need to dose modify, but persistent grade 3 or grade 4, you suspend and then reduce upon resolution. With elevated LFTs, again, you do need to think about holding if patients do have persistent elevation of grade 2 LFTs or grade 3 LFTs. So again, important to monitor this, particularly over the first 2 months. QTC prolongation is an issue with ribociclib, and again, does need to be monitored within that first month of therapy. And if there is QTC prolongation, usually we interrupt dosing and think about dose modification upon restarting. The other important thing with these oral medications is to think about strategies to help make sure they're taking these drugs. Obviously, they're not going to have benefit if they're not taking it. And it's challenging to take medications daily. So to make sure we're asking patients about adherence, figuring out why they may be missing doses, coming up with strategies to help them be consistent about taking medications, and then to help them with any of the adverse events that they're experiencing, again, to help improve persistence of treatment. So some strategies to think about when discussing adverse events. It's important, again, to focus on hydration, use of antidiarrheal therapy, making sure they're calling you if they're having symptoms and not just dealing with it on their own. And then not to hesitate to use dose modification to manage side effects. I think the things that we think are not so good is to avoid delays with initiation of dose reductions. That can lead to lack of persistence of drug therapy or discontinuation, and not to ignore symptoms that patients are experiencing. So coming back to our case, again, this is Amelia who is having diarrhea that was persistent despite an initial dose hold. And so this is a situation where I think another dose hold and dose reduction upon resolution would be very important to help her with her symptoms. Other things to keep in mind, again, is when you're monitoring her blood counts, realize that the creatinine, again, can be falsely elevated with the abemaciclib. And so to think about sending a cystatin C if you need to. And if patients do develop symptoms of ILD, to be very prompt about evaluation. So if someone, for example, comes in with a cough or shortness of breath, make sure you're getting a high resolution CT to evaluate why that may be. And if it does look like drug-induced toxicity, bilateral ground glass changes, for example, with no infectious etiology, then do think about abemaciclib-related ILD, hold drug, think about initiation of steroids, and then restarting upon resolution. So we'll come back to our case with some examples of how to communicate with our patients about adverse events and taking therapy.
Dr. Petoniak, the diarrhea from my treatment is continuing. It's really affecting my life.
Diarrhea, yeah, it's common. Well, drink fluids, take loperamide. That's all you can do, really.
I've tried loperamide, but it's not enough. Could we reduce the dose? Maybe that'd help. I mean, I've talked to a lot of other patients whose oncologists reduced their dose.
I wouldn't recommend a dose reduction. Stick to what I prescribe. Benefits outweigh the risks. If you want benefits, you have to keep up with it.
But what about quality of life? I mean, I can't go anywhere. I can't ride my bike. I can't go to work because I can't travel. I haven't done anything that I like to do for months now.
I would recommend that you continue doing what you have been doing to manage the diarrhea, and let's hope it gets better. And don't stop the pills. You have an increased risk of recurrence, remember?
I need more guidance. What if it gets worse?
Then call my nurse. She can give you help with some more tips and tricks. But if you stop treatment, no guarantees.
Doctor, the diarrhea from my treatment is continuing and it's really affecting my daily life.
I'm sorry to hear that, Amelia. I know you've had a tough time over the last, month or two with this drug. You've had to take a break already off of the medicine, and even after restarting it, it sounds like you're still having issues. How many times a day are you going to the bathroom?
Well, uh, it's a lot. I can't even go out of the house. I mean, I would say 4, 5 times.
Yeah, no, that's certainly not good and far too much. So I would say it's really important at this point in time to stop the abemaciclib and give your body a break. I know we've taken a break before, but I think this time I'd like to give you a break and wait until, your bowels go back to normal. And then once they're back to normal, we would like to restart things with a lower dose. So, for example, right now you've been taking the full dose, which is 150 milligrams 2 times a day. But once things are better, we could start at a much, go down a dose, which is going to 100 milligrams and take that twice a day. And we usually find that when we reduce the dose, that the amount of diarrhea gets to be much better. But for now, I think it's really important that we stop it, that you get very well hydrated, and that we can use some of that loperamide to keep things controlled. Have you been using that medicine, the loperamide, to stop the diarrhea at all?
No, I haven't been taking the over the counter. What was the name of that?
It's called loperamide.
Okay. Do you think that that would help?
Yeah, I think for now, what I would say is don't take the abemaciclib anymore.
Okay.
And if you're still having the loose stool, then I would take the loperamide to slow it down. It'll make that diarrhea, stop, hopefully. And I would make sure that you are drinking lots of fluids. So have you been able to keep yourself hydrated and drinking a lot at home?
I've been trying to, but obviously I probably haven't been doing that good of a job.
Well, so I would definitely, make sure that you're drinking at least, 6 to 8 glasses of fluids, water, and things like that are good. And then to watch your diet so that, you're not eating a diet that has a ton of fiber in it. So, not, I know it doesn't sound like as healthy when I'm telling you not to eat big salads and tons of vegetables, but sometimes those are a little hard on the stomach right now. So we'll just give your stomach a little break from that kind of stuff right now. But
Um,
oh, go ahead.
I was going to say it's just kind of it's hard to remember to take the pills regularly, and you know some of these side effects are not pleasant. But then I think about the long term consequences, and I'm willing to do whatever it takes.
Yeah, no, I know it's been really hard, and I'm sorry, Amelia, that it's been so tough. But I do think if we give your body a bit of a break and let things improve, I think you're going to find the lower dose a lot better, and much more tolerable. And it turns out that we have data to suggest that even the lower dose is highly effective. There was no difference in the benefits that people gained from the abemaciclib if they took the full 150 milligram dose or the 100 milligram dose. So I think that's very reassuring and definitely makes it important to try the lower dose.
Okay, then.
So let's give yourself a break off this medicine. You'll take your loperamide and drink lots of fluids, and then I'd like to see you back in a week. And if you're doing better, then we could start on the lower dose and see how that goes.
Sounds good. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, Living Beyond Breast Cancer. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/BZV860.